Supraventricular tachycardia is the most common sustained arrhythmia in newborns. It is defined in infants by a heart rate above about 220 beats per minute with very little variability. Unlike sinus tachycardia, the rate does not rise and fall with activity or stimulation, but remains fixed. The most common mechanism in this age group is an accessory conduction pathway creating a reentry circuit, often associated with Wolff-Parkinson-White pattern. This allows impulses to circle rapidly between the atria and ventricles, driving the very high heart rate. Clinically, presentation depends on duration. A brief episode may cause only irritability or poor feeding, but prolonged SVT can produce tachypnea, hepatomegaly, or overt congestive heart failure, as the ventricle tires under the high demand. On ECG, the rhythm typically shows a narrow QRS complex because conduction still travels through the His-Purkinje system. If conduction is aberrant, a wide complex may appear, which can mimic ventricular tachycardia, but careful review usually reveals retrograde atrial activity. Recognizing SVT is critical because untreated episodes can compromise cardiac output. Prompt diagnosis and acute management with vagal maneuvers or adenosine are often effective, while long-term strategies may involve prophylactic medications until the conduction system matures. The treatment of supraventricular tachycardia follows a structured algorithm that prioritizes safety and rapid restoration of normal rhythm. Step 1 is vagal stimulation. Simple maneuvers like applying ice to the face or gentle pressure to the eyelids can trigger increased vagal tone and interrupt the reentry circuit. These methods are safe and often effective in neonates. If vagal maneuvers fail, the next step is adenosine. The starting dose is 0.1 milligrams per kilogram, given as a rapid intravenous push, followed immediately by a saline flush. If ineffective, the dose is increased to 0.2 milligrams per kilogram. Because the drug has a half-life of less than 10 seconds, proper administration is critical. The two-syringe technique, with adenosine in one and saline in the other, ensures the medication reaches the heart quickly. If the infant is hemodynamically unstable, such as with hypotension or poor perfusion, synchronized cardioversion is indicated without delay. For long-term prevention of recurrence, maintenance therapy may be used. Digoxin, beta blockers, or flecainide are common choices tailored to the infant's physiology and any underlying structural heart disease. Many infants outgrow SVT as the conduction system matures, so chronic therapy is often temporary. This stepwise approach ensures both rapid stabilization in acute episodes and safe prevention of recurrences during early infancy. Heart block in the newborn is most often linked to maternal autoimmune disease, particularly the transfer of anti-Rho and anti-La antibodies across the placenta. These antibodies injure the fetal conduction system, producing varying degrees of atrioventricular block. First-degree block appears as simple prolongation of the PR interval beyond 180 milliseconds. Second-degree block means some atrial impulses fail to reach the ventricles, producing dropped beats. Complete heart block is the most severe form, with no atrial conduction at all. In this case, ventricular escape rhythms usually maintain rates between 50 and 80 beats per minute. The clinical impact depends on ventricular rate and cardiac output. Many infants with complete block remain stable at birth, but those with poor perfusion, heart failure, or very slow rates may require pacemaker placement. Maternal lupus is a particularly high-risk setting. Pregnancies complicated by this condition warrant careful fetal monitoring, since conduction abnormalities can develop in utero and be permanent by delivery. Understanding this association helps explain why newborns of mothers with autoimmune disease are closely followed, and why early recognition of bradycardia on fetal or neonatal monitoring should raise concern for congenital heart block. Electrocardiography can provide important diagnostic clues in congenital heart disease, especially when combined with the clinical picture. In tricuspid atresia, the absence of right ventricular inflow forces the left ventricle to carry the workload. The ECG shows left axis deviation and signs of left ventricular hypertrophy, an unusual finding in a newborn and highly suggestive of this lesion. Tetralogy of Fallot presents differently. Outflow obstruction and right-sided pressure load create right axis deviation and right ventricular hypertrophy, which are the expected patterns. In transposition of the great arteries, the right ventricle functions as the systemic ventricle, The ECG therefore shows right ventricular hypertrophy, and the axis is often normal or rightward. Hypoplastic left heart syndrome produces a striking pattern. The right ventricle is the systemic pump, so there is right ventricular hypertrophy, while left-sided forces are small or absent because the left ventricle is underdeveloped. For comparison, a normal newborn ECG shows right axis deviation and relative right ventricular dominance. This reflects fetal circulation, where the right ventricle handles most of the cardiac output. Recognizing when the expected right axis pattern is replaced by left axis deviation or when hypertrophy is out of proportion to age helps direct attention to specific defects before imaging is obtained. Prostaglandin E1 is one of the most important emergency therapies in neonatal cardiology. Its role is to maintain ductal patency in situations where survival depends on continued flow through the ductus arteriosus. For ductal-dependent systemic circulation, such as hypoplastic left heart syndrome, critical aortic stenosis, or severe coarctation, the ductus provides the only reliable pathway for blood to reach the body. If it constricts, systemic perfusion collapses. For ductal-dependent pulmonary circulation, including pulmonary atresia, critical pulmonary stenosis, and severe tetralogy of Fallot, the ductus serves as the sole or major source of pulmonary blood flow. Closure in these cases leads to profound cyanosis. Prostaglandin is also used when mixing is inadequate, as in transposition with restrictive atrial communication, where ductal flow buys time until a septostomy can be performed. A critical concept is using PGE1 as a bridge to diagnosis. In a neonate with unexplained shock or cyanosis, starting prostaglandin before the anatomy is found fully defined can stabilize the infant and prevent collapse. The principle is simple. Start first, ask questions later. Recognizing these indications and acting quickly is a defining skill in neonatal intensive care, since minutes can make the difference between recovery and irreversible injury. Prostaglandin E1 must be given as a continuous infusion because of its very short half-life, only about 5 to 10 minutes. The initial dose is typically 0.05 to 0.1 micrograms per kilogram per minute delivered intravenously. Once ductal patency and clinical stability are achieved, the infusion should be reduced to the lowest effective dose, usually 0.01 to 0.05 micrograms per kilogram per minute, to limit side effects. Administration is ideally through a central line for reliability and safety, though peripheral access may be used in emergencies until central access is secured. A dedicated infusion pump is essential to ensure accurate, uninterrupted delivery. Titration is guided by clinical response. Improved oxygen saturation, stronger pulses, and better systemic perfusion indicate effective dosing. Because the drug works so quickly and clears so rapidly, interruption of the infusion can result in ductal closure within minutes, so continuous vigilance is required. This pharmacology underscores why PGE1 is considered a true emergency medication. Its immediate effects can be life-saving, but only if delivered consistently and monitored closely. The most serious side effect of prostaglandin E1 is apnea, which occurs in about 10 to 20% of infants and is especially common in those under 2 kilograms. Because this risk is significant, every initiation of PGE1 should be treated as a potential airway emergency. Intubation equipment and staff must be ready before the infusion begins. Other side effects are generally less dramatic, but still clinically important. These include fever, hypotension from vasodilation, and metabolic disturbances such as hypoglycemia. Seizures are rare but have been reported, usually in association with high doses or prolonged use. Continuous monitoring is required, both respiratory and cardiac. Even infants who appear stable can deteriorate suddenly if apnea or hypotension develops. Weaning should be done cautiously. The infusion is reduced stepwise with close attention to oxygenation and perfusion. Any sign of deterioration means the dose must be raised again. These safety considerations emphasize that while PGE1 is life-saving, it is also high risk, and starting the infusion should always include preparation for its most dangerous complication. Dopamine is one of the most commonly used pressors in the NICU, and its effects are dose-dependent. At low doses, around 2 to 5 micrograms per kilogram per minute, it stimulates dopaminergic receptors, producing renal and mesenteric vasodilation. At moderate doses, 5 to 10 beta-1 effects predominate, improving heart rate and contractility. At higher doses, 10 to 20, alpha-adrenergic stimulation dominates, causing systemic vasoconstriction and raising blood pressure. This tiered response makes dopamine versatile. It is often used as a first-line agent for neonatal hypotension because it can support both cardiac output and systemic vascular resistance depending on the clinical need. Titration is gradual, starting at 2 to 5 micrograms per kilogram per minute and increasing by 2.5 to 5 every 5 to 10 minutes until the desired effect is achieved. Close monitoring is essential, as infants may have variable sensitivity. Side effects include tachycardia and arrhythmias due to excessive beta stimulation. Extravasation is another risk, since dopamine is a vesicant and can cause local tissue injury if the infusion infiltrates. Understanding these dose-dependent mechanisms helps match the drug's pharmacology to the infant's physiology, ensuring effective support while minimizing complications. Adenosine is the first-line medication for supraventricular tachycardia in neonates because of its rapid and predictable action at the atrioventricular node. It binds to A1 receptors, creating a transient AV block. This interruption of conduction stops the reentry circuit driving most SVTS and allows sinus rhythm to resume. Beyond treatment, adenosine can be used diagnostically. If the rhythm terminates, SVT is confirmed. If conduction is only slowed and the tachycardia persists, the diagnosis may be atrial tachycardia or even ventricular tachycardia. Dosing begins at 0.1 milligrams per kilogram with a maximum of 6 milligrams. If the first dose fails, a second dose of 0.2 milligrams per kilogram up to 12 milligrams can be given. Because the drug's half-life is less than 10 seconds, administration must be extremely rapid, ideally pushed in under 1 to 2 seconds, followed immediately by a saline flush. The expected effect is a brief pause in conduction. Transient asystole for 5 to 15 seconds is common and can look dramatic, but it is anticipated and usually followed by conversion to sinus rhythm. Adenosine's safety profile and speed make it the cornerstone of acute SVT management, but only when staff are prepared for its brief but striking effects. Shock in neonates can arise from several different physiologic mechanisms, and early recognition of the type guides therapy. Hypovolemic shock is the most common in pediatrics, caused by loss of circulating volume through bleeding, third spacing, or dehydration. These infants typically respond well to volume replacement. Cardiogenic shock develops when the myocardium cannot generate sufficient output. In neonates, this often results from congenital heart disease, arrhythmias, or severe myocardial dysfunction. Excessive fluid administration can worsen pulmonary congestion, so management emphasizes inotropic support with cautious fluid use. Distributive shock occurs when systemic vasodilation lowers effective vascular resistance, most often from sepsis. The circulation appears expanded despite normal or high cardiac output. These infants require fluid resuscitation, vasopressors, and urgent antimicrobial therapy. Obstructive shock is distinct in that cardiac output is impaired by an external mechanical barrier rather than intrinsic heart failure. Examples include pericardial tamponade, compressing the ventricles, tension pneumothorax, collapsing venous return, or pulmonary embolism obstructing flow. These cases demand rapid relief of the obstruction, such as pericardiocentesis or chest decompression, since fluids and inotropes alone are ineffective. The unifying principle is that each form of shock requires tailored treatment, and giving the wrong therapy can worsen the infant's condition. Importantly, neonates often preserve blood pressure until late in the course, making early bedside signs, such as tachycardia, prolonged capillary refill, and lethargy more reliable than hypotension. Hypovolemic shock is the form of shock most often seen in pediatrics, and in neonates it is usually related to blood loss, dehydration, or fluid shifts. The earliest clinical signs are subtle. Tachycardia, prolonged capillary refill, and cool extremities appear before blood pressure falls, because neonates maintain pressure until very late in the course. Initial management begins with rapid vascular access, ideally intravenous but intraosseous if necessary. Fluid resuscitation is started with 20 milliliters per kilogram of isotonic crystalloid, delivered quickly. Boluses can be repeated while closely monitoring the response. Indicators of improvement include normalization of heart rate, stronger pulses, warmer extremities, improved urine output, and better alertness. Lack of response after 2 or 3 boluses should raise concern for ongoing bleeding or an alternate type of shock. If blood loss is suspected or confirmed, blood products must be given rather than additional crystalloid alone. At the same time, the underlying cause must be addressed, whether it is hemorrhage, dehydration, or third spacing from illness such as sepsis. This structured approach, early recognition, rapid fluid replacement, and correction of the underlying problem, restores circulation before decompensation occurs. Cardiogenic shock in neonates is distinct because the heart itself is the failing organ. Clinically, it presents with poor perfusion, but unlike hypovolemic shock, there are also signs of congestion. Hepatomegaly from venous congestion or pulmonary rales from fluid overload point toward impaired cardiac function rather than volume loss. Hemodynamically, cardiac output is reduced and filling pressures are elevated, so giving large fluid boluses worsens the problem. The priority is to support contractility while avoiding additional preload. Inotropic agents are central to therapy. Dopamine at 5 to 20 micrograms per kilogram per minute or dobutamine at 2.5 to 20 can improve myocardial performance. Milrinone may also be used to enhance contractility and reduce afterload without increasing oxygen consumption. ACE inhibitors can further reduce afterload once the infant is stable, easing ventricular workload. If despite optimized medical management, the infant remains in shock, extracorporeal membrane oxygenation may be necessary to provide full circulatory support while recovery or surgical intervention is pursued. Recognizing the combination of poor perfusion with congestion and avoiding unnecessary fluid are key steps that separate management of cardiogenic shock from other shock states in the NICU. Blood pressure interpretation in neonates requires both numbers and context. For term infants, normal systolic values on day 1 range from about 60 to 76, with diastolic from 31 to 45. By day 3, values rise slightly, with systolic 72 to 88 and diastolic 43 to 58. For preterm infants, a useful rule of thumb is that the mean arterial pressure in the first 48 hours should be at least equal to the gestational age in weeks. For example, a 26-week infant should have a mean pressure of 26 millimeters of mercury or higher. Accurate measurement is essential. The cuff should be about 40% of the arm circumference, and in critical infants, pressures should be checked in all 4 extremities to assess for coarctation. Hypotension is defined not only by numbers, but also by physiology. A mean pressure below gestational age is concerning, but equal weight must be given to clinical signs such as weak pulses, delayed capillary refill, or altered mental status. This approach emphasizes that numbers provide a framework, but the true assessment of blood pressure in neonates combines accurate measurement with direct observation of perfusion. Hypertension in neonates is defined as systolic or diastolic pressure above the 95th percentile for age. Unlike in older children, it is often discovered incidentally during routine monitoring rather than because of symptoms. The most common cause is renovascular disease, particularly renal artery thrombosis, which may follow umbilical arterial catheterization. Cardiac causes must also be considered, with coarctation of the aorta being the most frequent. For this reason, 4-extremity blood pressures are always required when elevated readings are found. Because many neonates show no obvious symptoms, consistent measurement is critical. When hypertension is severe, it can present with irritability, feeding problems, or in rare cases, seizures. But most cases are silent. Recognition matters because untreated hypertension can lead to long-term cardiac and renal damage. Identifying renovascular and cardiac causes early allows targeted therapy rather than relying solely on antihypertensive medications. Management of congestive heart failure in neonates focuses on reducing symptoms and supporting growth until definitive repair can be performed. The first-line therapy is diuretics. Furosemide at 0.5 to 2 milligrams per kilogram every 6 to 12 hours helps relieve pulmonary congestion and systemic edema by reducing volume overload. ACE inhibitors such as captopril are used for afterload reduction. By lowering systemic vascular resistance, they make it easier for the ventricle to eject blood forward, improving efficiency and reducing regurgitant flow. Digoxin, once a mainstay, is now used less commonly but still has a role. At 2 to 4 micrograms per kilogram per day, it provides inotropic support by enhancing contractility and slowing conduction through the AV node. Its use requires careful monitoring for toxicity, especially in infants with renal impairment or electrolyte disturbances. Nutritional support is just as important as pharmacology. High-calorie feeds or supplementation are often needed because infants with heart failure burn more calories through tachypnea and work of breathing. Adequate growth is a key marker of successful management while awaiting surgical intervention. The overarching goal is to stabilize hemodynamics and maintain growth potential, ensuring the infant reaches surgery in the best possible condition. Ebstein's anomaly is a rare but striking lesion defined by downward displacement of the tricuspid valve into the right ventricle. This creates an atrialized portion of the ventricle and leaves the functional right ventricle small and inefficient. The clinical spectrum is wide. Some patients are not diagnosed until adulthood with mild disease, while others present in the newborn period with life-threatening physiology. In neonates, the valve malformation can cause functional pulmonary atresia, massive cardiomegaly, and profound cyanosis. On chest X-ray, the heart often appears balloon-shaped, with a cardiothoracic ratio greater than 0.7, a classic finding that should raise immediate suspicion. Associated lesions are common. About 80% of patients have an atrial septal defect or patent foramen ovale, which permits right to left shunting. 10 to 20% also have Wolff-Parkinson-White syndrome, predisposing them to arrhythmias. This combination of severe structural abnormality, shunting, and rhythm disturbance explains the highly variable course of Ebstein's anomaly. Early recognition of the neonatal presentation is critical, since management may involve prostaglandin infusion, arrhythmia control, and early surgical consultation. Pulmonary atresia with intact ventricular septum is a lesion where the pulmonary valve is completely imperforate, preventing any forward flow into the pulmonary arteries. Right ventricular size is highly variable. In some infants, the ventricle is adequate to support a biventricular circulation, while in others it is severely hypoplastic, committing them to a single ventricle pathway. Clinically, these babies present with severe cyanosis immediately after birth, since pulmonary blood flow is entirely ductal dependent. If the ductus closes, pulmonary circulation is lost, and profound hypoxemia follows. Initial stabilization requires prostaglandin E1 to maintain ductal patency. If atrial-level communication is restrictive, a balloon atrial septostomy may be needed to allow systemic venous blood to cross into the left atrium and reach systemic circulation. Management strategy is guided by right ventricular development. In infants with an adequately sized ventricle, interventions may allow for eventual biventricular repair. If the ventricle is too small, a univentricular staged pathway similar to the Fontan sequence is required. Because of this variability, pulmonary atresia with intact ventricular septum is among the more complex lesions, often requiring staged procedures and careful long-term planning. Double outlet right ventricle is defined by both great arteries arising primarily from the right ventricle. Because there is no normal left ventricular outflow, systemic circulation depends on how the left ventricle connects to the right through a ventricular septal defect. Classification is based on VSD location. A subaortic VSD allows left ventricular blood to reach the aorta more directly, while a subpulmonary VSD favors flow to the pulmonary artery, often creating physiology similar to transposition. Doubly committed and remote, VSDs present additional complexity. The clinical picture varies with this anatomy. Some infants present with cyanosis if systemic flow is compromised, while others develop heart failure from pulmonary overcirculation. Associated lesions such as outflow tract obstruction or arch hypoplasia further influence presentation. Surgical repair is tailored to each case. The goal is to close the VSD in a way that channels left ventricular output to the aorta. In some configurations, an arterial switch operation is also needed. Because of the variability, detailed preoperative imaging and planning are essential. This lesion illustrates how small anatomic differences can create widely different physiology, making careful assessment critical before surgical decision-making. Extracorporeal membrane oxygenation can provide life-saving support in neonates with severe cardiac disease. The type of ECMO matters. Veno-arterial ECMO supports both the heart and lungs, making it the mode of choice in cardiogenic shock, while veno-venous ECMO supports only respiratory function and is not sufficient when cardiac output is failing. Indications for cardiac ECMO include refractory cardiogenic shock, inability to wean from bypass after surgery, and use as a bridge to recovery, transplant, or ventricular assist device. Contraindications are equally important. Irreversible multi-organ failure or uncontrollable bleeding makes ECMO unlikely to succeed and adds risk. Complications are frequent and serious. They include bleeding from anticoagulation, thrombosis within the circuit, line or cannula-related infections, and secondary organ dysfunction from the stress of prolonged support. Despite these challenges, ECMO remains an important tool. In neonatal cardiac patients, survival is roughly 30 to 50%, with outcomes depending on the underlying diagnosis and the reason for support. Recognizing when ECMO is appropriate requires careful assessment, but in selected infants, it provides the only chance to bridge through otherwise unsurvivable cardiac failure. Surgical timing in congenital heart disease is carefully matched to the physiology of each lesion. In the neonatal period, certain repairs cannot be delayed. The arterial switch for transposition of the great arteries must be done within the first weeks of life before the left ventricle loses its conditioning to pump systemically. Obstructed total anomalous pulmonary venous return is a surgical emergency, requiring immediate correction. Hypoplastic left heart syndrome requires a Norwood procedure in the first days of life to establish systemic output. In infancy, other complex defects are repaired once the baby is larger and better able to tolerate surgery. Tetralogy of Fallot is usually corrected between 6 and 12 months, and truncus arteriosus often requires a Rastelli-type repair in that same window to prevent pulmonary vascular disease. Staged procedures are used for single ventricle physiology. The Glenn shunt is performed around 4 to 6 months, diverting superior vena cava return directly to the lungs. The Fontan procedure follows at 2 to 4 years, completing the total cavopulmonary connection. The unifying principle is that early intervention is often better than delay. Timely surgery prevents complications such as irreversible pulmonary vascular disease or ventricular dysfunction, ensuring the best possible long-term outcomes. Post-operative complications after congenital heart surgery are common and require close vigilance in the first hours to days. One of the most important is low cardiac output syndrome, which usually appears within 6 to 24 hours. Myocardial stunning, edema, and residual lesions all contribute, and without support, end-organ perfusion quickly declines. Arrhythmias are also frequent. Junctional ectopic tachycardia is a narrow complex rhythm that often follows surgery near the atrioventricular node. It produces rapid heart rates with loss of atrial contribution to filling, which worsens cardiac output. Management strategies include cooling, minimizing catecholamines, and sometimes antiarrhythmics. Heart block can occur if conduction tissue is injured, such as during VSD closure near the septum. This may be temporary, but in some cases requires permanent pacing. Temporary pacing wires placed at surgery are invaluable for bridging until recovery or device implantation. Bleeding is another major concern. Cardiopulmonary bypass disrupts coagulation and platelet function, and surgical sites may ooze. While transfusion and correction of coagulopathy are first steps, some infants require re-exploration in the operating room. Careful monitoring for these complications and rapid escalation when they occur is central to improving outcomes after neonatal cardiac surgery. Certain congenital heart defects are tightly linked to genetic syndromes, and recognizing these associations can guide both cardiac and non-cardiac management. The 22q11.2 deletion, seen in DiGeorge syndrome, is associated with conotruncal anomalies including truncus arteriosus, interrupted aortic arch, and tetralogy of Fallot. Because of the immune and metabolic issues in this syndrome, early identification impacts perioperative planning. Trisomy 21 is strongly tied to endocardial cushion defects. About 40 to 50% of affected infants have atrioventricular canal defects, making careful cardiac evaluation essential in all newborns with Down syndrome. Turner syndrome is associated with left-sided lesions, most commonly bicuspid aortic valve and coarctation. These patients also carry risks of systemic hypertension and aortic dilation later in life. Noonan syndrome frequently involves pulmonary stenosis, particularly with dysplastic valves, and may also present with hypertrophic cardiomyopathy. Williams syndrome is classically associated with supravalvular aortic stenosis, along with distinctive facies and developmental features. Recognizing these patterns ensures that a cardiac lesion prompts genetic evaluation and that a genetic diagnosis prompts careful cardiac screening, creating a bidirectional approach that improves detection and care. Several maternal factors increase the risk of congenital heart disease or rhythm disturbance in the newborn. Maternal diabetes is one of the best recognized. Infants may develop hypertrophic cardiomyopathy from excess glycogen deposition in the myocardium, and there is also increased risk for structural defects such as ventricular septal defect and coarctation. Maternal lupus with anti-Ro or anti-La antibodies can cross the placenta and injure the fetal conduction system. This leads to congenital heart block, which may present as persistent fetal or neonatal bradycardia, and sometimes requires pacing. Certain medications are teratogenic. ACE inhibitors can impair fetal renal and cardiovascular development. Lithium is linked to Ebstein's anomaly. And anticonvulsants such as valproic acid are associated with multiple malformations, including cardiac. Torch infections, such as rubella, cytomegalovirus, and toxoplasmosis, have variable cardiac effects ranging from structural malformations to myocarditis. Finally, maternal age is a general risk factor. Advanced maternal age is associated with higher rates of chromosomal abnormalities, which often carry cardiac defects, such as trisomy 21 and atrioventricular canal defects. Appreciating these associations helps identify infants who warrant early screening and echocardiography, improving the chance of timely diagnosis and intervention. Endocarditis. Prophylaxis is reserved for children with the highest risk of life-threatening infection. These include those with prosthetic valves, a history of prior endocarditis, unrepaired cyanotic congenital heart disease, and those with surgical shunts or conduits. Prophylaxis is no longer recommended for most repaired congenital lesions unless there are residual defects. This shift reflects evidence that the absolute risk is low, and routine prophylaxis is not beneficial for the majority of patients. When indicated, prophylaxis is given for dental procedures that involve gingival manipulation or perforation of the oral mucosa. The standard regimen is amoxicillin at 50 milligrams per kilogram orally administered 1 hour before the procedure. Alternatives are available for patients with penicillin allergy. Beyond antibiotics, prevention depends on maintaining good oral hygiene and avoiding high-risk exposures. Even routine dental care is protective because poor oral health is a major source of bacteremia. High-risk patients should also be counseled to avoid body piercing or tattooing, which carry additional risk of bacteremia and infection. The focus is therefore on carefully selecting who truly needs prophylaxis and reinforcing daily preventive strategies that reduce the risk of endocarditis over a lifetime. Neurodevelopmental outcomes are an increasingly important focus in children surviving complex congenital heart disease. About 20 to 30% develop measurable difficulties, making this one of the most common long-term complications. Several risk factors contribute: preoperative hypoxemia, prolonged cardiopulmonary bypass time, use of deep hypothermic circulatory arrest, and the burden of multiple surgeries all increase the likelihood of injury to the developing brain. The issues most often seen are subtle but impactful. Executive function deficits, attention disorders, and learning disabilities are common. These challenges may not emerge until school age, but they directly affect academic performance and quality of life. Early intervention is essential. Developmental assessments should begin in the NICU with follow-up educational evaluations and therapy services as the child grows. Targeted support in speech, motor, and cognitive domains can mitigate long-term effects. Routine screening is now considered part of standard care. Identifying risk early allows families and care teams to prepare, ensuring that children with CHD not only survive, but also achieve the best possible developmental outcomes. Long-term cardiac outcomes vary widely depending on the lesion and type of repair. For transposition of the great arteries, the arterial switch operation has transformed survival. More than 95% of patients are alive at 20 years with generally good function. Tetralogy of Fallot also carries strong outcomes after complete repair, with survival around 90 to 95%. However, many will eventually require intervention for pulmonary regurgitation or right ventricular dilation. Single ventricle physiology managed with Fontan palliation is more complex. Only about 60 to 80% reach Fontan completion. And even those who do face long-term risks, including arrhythmias, protein-losing enteropathy, and eventual ventricular dysfunction. Across all groups, late complications are common. Conduits placed in infancy often require replacement as the child grows, valves may develop regurgitation, and arrhythmias increase with age and surgical scarring. These realities mean that most patients with congenital heart disease will undergo multiple procedures over their lifetime. Excellent survival is now the norm for many defects, but lifelong surveillance and reintervention remain central to care. Transition to adult care is a critical step for congenital heart disease survivors, and preparation must begin well before transfer. Structured programs typically start in early adolescence, helping patients and families gradually shift responsibility for health management. Education is central. Adolescents need clear knowledge of their diagnosis, medications, activity restrictions, and the importance of lifelong follow-up. Without this foundation, adherence often falters once pediatric oversight ends. Reproductive counseling is another essential element. Many forms of congenital heart disease carry specific pregnancy risks, and contraception choices must be tailored to the cardiac condition. Addressing these issues early empowers young adults to make safe decisions. Barriers to smooth transition are common. Insurance gaps, shortages of adult congenital heart disease specialists, and lack of patient readiness all threaten continuity of care. Addressing these obstacles requires planning at both the individual and system level. Even in the NICU, the groundwork can be laid. By educating families that congenital heart disease requires lifelong care, clinicians set expectations early. This seed, planted at diagnosis, grows into successful transition later. Pregnancy in women with congenital heart disease requires careful risk stratification and specialized care. The World Health Organization classification provides a practical framework. Class 1, the low-risk group, includes women with small, unrepaired VSDS, ASDS, or PDAS, as well as those with successfully repaired simple lesions. These pregnancies usually proceed without major complications. Class 3 represents high risk. Women with a systemic right ventricle, Fontan circulation, or persistent cyanotic heart disease face significant maternal and fetal risks, and pregnancy should only proceed with close expert management. Class 4 is considered extremely high risk, and pregnancy is contraindicated. This includes women with pulmonary hypertension or Eisenmenger syndrome, where maternal mortality can exceed 50%. Preconception counseling is essential. It should include a detailed medication review, since drugs such as ACE inhibitors or warfarin may be teratogenic, along with assessment of maternal risk and genetic counseling. Offspring risk is about 3 to 5% if one parent is affected, and rises to 10 to 15% if both parents carry congenital heart disease. These principles highlight why women with CHD require multidisciplinary care, and why counseling ideally begins long before conception. Recognition of cardiac disease in neonates often depends on recognizing patterns rather than isolated findings. Timing is one of the most important clues. Infants who present in the first week of life often have ductal-dependent lesions, since symptoms emerge as the ductus begins to close. By contrast, left-to-right shunts such as VSD or AV canal usually appear weeks to months later, once pulmonary vascular resistance falls and shunting increases. Certain patterns on exam are highly suggestive. Differential cyanosis, where upper and lower body saturations differ, points toward conditions like transposition with a PDA or interrupted aortic arch. A chest X-ray showing massive cardiomegaly in a newborn should immediately raise suspicion for Ebstein's anomaly. Another critical pattern is the sepsis-like presentation of critical cortation. These infants may appear to have infection with poor perfusion, acidosis, and shock. But the underlying problem is loss of ductal flow to the systemic circulation. Being alert to these recognition patterns allows clinicians to distinguish cardiac from non-cardiac disease quickly, ensuring timely initiation of prostaglandin and referral for definitive care. Emergency management of a critically ill neonate with suspected heart disease begins with the basics. Airway, breathing, and circulation must be assessed and stabilized first, since hypoxemia and poor perfusion rapidly worsen underlying physiology. Fore extremity blood pressures should be obtained early to screen for coarctation, and pre- and post-ductal saturations help differentiate cardiac from pulmonary disease. A significant difference in saturations, especially if unresponsive to oxygen, suggests a shunt lesion. If there is any suspicion of a ductal-dependent lesion, prostaglandin E1 should be started immediately. Waiting for a definitive diagnosis risks circulatory collapse. Because apnea occurs in up to 20% of infants receiving PGE1, preparation for intubation must occur at the same time. Early consultation with pediatric cardiology is essential. Many of these conditions are time-sensitive, requiring interventions such as balloon atrial septicectomy or urgent surgery. The priority is stabilization and buying time for diagnosis and transfer, with rapid recognition and action making the difference between recovery and irreversible decompensation. The key themes in neonatal cardiac care come down to recognition, physiology, and timely action. Early recognition is critical, and the timing of presentation often points directly toward the diagnosis. Ductal-dependent lesions appear in the first week as the ductus closes, while left-to-right shunts present later as pulmonary vascular resistance falls. Every clinical decision rests on hemodynamics. Knowing the direction of a shunt and the pressure relationships between chambers explains why symptoms develop and what interventions will help or harm. This physiologic reasoning is what separates effective care from guesswork. Emergency management centers on a few life-saving strategies. Prostaglandin E1 should be started immediately if a ductal-dependent lesion is suspected, and supraventricular tachycardia requires a clear stepwise protocol beginning with vagal maneuvers and adenosine. Pattern recognition of classic associations also matters. Genetic syndromes like trisomy 21, 22q, 11.2 deletion, and Noonan, as well as maternal factors such as lupus or diabetes, point strongly toward particular cardiac diagnoses. Finally, it is important to maintain the long-term perspective. With modern care, most children with congenital heart disease survive into adulthood, but their outcomes depend heavily on the foundation set in the NICU. Excellent early stabilization, accurate diagnosis, and comprehensive family support lay the groundwork for a lifetime of successful management. A 2-day-old term neonate presents with severe cyanosis that doesn't improve with oxygen administration. The echocardiogram shows the aorta arising from the right ventricle and the pulmonary artery from the left ventricle. The most likely diagnosis is hypoplastic left heart syndrome, transposition of the great arteries, truncus arteriosus. The correct choice is transposition of the great arteries. This question is testing your ability to identify congenital heart defects based on their key anatomical features. Hypoplastic left heart syndrome is incorrect because it involves underdevelopment of the left ventricle, mitral valve, and aortic valve, not abnormal connections of the great vessels. Truncus arteriosus is incorrect because it involves a single arterial trunk arising from both ventricles rather than two vessels with abnormal connections. A 3-day-old neonate with coarctation of the aorta presents with poor peripheral perfusion, weak femoral pulses, and metabolic acidosis. The most appropriate initial management is dobutamine infusion at 10 micrograms per kilogram per minute, furosemide 1 milligram per kilogram intravenous, prostaglandin E1 infusion at 0.05 micrograms per kilogram per minute. The correct choice is prostaglandin E1 infusion at 0.05 micrograms per kilogram per minute. This question is testing your knowledge of management priorities for ductal-dependent lesions. Dobutamine infusion is incorrect because while it may temporarily improve cardiac output, it doesn't address the underlying anatomic problem of ductal-dependent systemic circulation. Furosemide is incorrect because diuresis would be harmful in this scenario where the patient is already underperfused. Improving ductal flow is the immediate priority. A 28-week preterm infant has an echocardiogram showing a hemodynamically significant patent ductus arteriosus. Which finding would not be expected on physical examination? Bounding peripheral pulses, decreased pulse pressure, machinery murmur below the left clavicle. The correct choice is decreased pulse pressure. This question is testing your understanding of the hemodynamic consequences of a PDA and its clinical manifestations. Bounding peripheral pulses are incorrect as an answer because they are a classic finding with PDA due to the rapid runoff of blood during diastole. Machinery murmur is incorrect as an answer because this continuous murmur is characteristic of PDA. A widened, not decreased, pulse pressure is expected with PDA due to diastolic runoff into the pulmonary circulation. A 1-week-old term infant has a harsh hollow systolic murmur, best heard at the lower left sternal border. The infant is feeding well and has no respiratory distress. This finding is most consistent with atrial septal defect, patent ductus arteriosus, ventricular septal defect. The correct choice is ventricular septal defect. This question is testing your ability to correlate heart murmur characteristics with specific cardiac defects. Atrial septal defect is incorrect because it typically produces a systolic ejection murmur at the upper left sternal border, not a hollow systolic murmur at the lower sternal border. Patent ductus arteriosus is incorrect because it creates a continuous machinery murmur best heard below the left clavicle rather than a hollow systolic murmur. In a 2-week-old infant with a moderate ventricular septal defect, which physiologic change would increase left to right shunting across the defect? Decreased pulmonary vascular resistance, increased pulmonary vascular resistance, increased systemic vascular resistance. The correct choice is increased systemic vascular resistance. This question is testing your understanding of cardiac pathophysiology and the factors that affect shunt direction and magnitude. Decreased pulmonary vascular resistance is incorrect as an answer choice because while it would indeed increase left to right shunting, the question asks which factor would increase shunting. Increased pulmonary vascular resistance is incorrect because it would actually decrease left to right shunting or potentially reverse it to right to left if severe enough.